Good morning, and thank you to Virology Education for the opportunity to present this overview and update on intermittent antiretroviral therapy, taking ART less than every day. I want to begin by thanking people living with HIV who've generously participated in studies of intermittent therapy. So why take ART less than every day? For as long as ART has existed, it's been recognised that taking ART every day or tablets every day is a significant burden, and individuals may want to take a break, for example, at weekends. Adherence is also a complex challenge for many people, and planned breaks might make this easier for some. While ART has hugely progressed over the years, there are recognised long-term toxicities. Reducing cumulative ART exposure could, for example, minimise the impacts on metabolic risk, bone health, and renal function in the long term. And fewer tablets could also save ART-related costs. For these reasons, people have been studying whether it could be possible to take ART less than every day for a really long time. And it's worth mentioning that once-weekly tablets are under development, and long-acting injectables, of course, already exist. But what I'm talking about here is taking once-daily regimens, but then taking these intermittently. Initial ART studies were not successful. In 2003, the Staccato study found that a 7 days on, 7 days off approach led to excess virological failure. And the SMART study evaluated intermittent treatment based on CD4 count. But this study was stopped early after showing that this increased the risk of opportunistic infection and death from any cause. Next, a different approach was evaluated, with ART given 4 or 5 days per week, with 2 to 3 days of no treatment. In 2007 and 2010, pilot studies of this strategy using NNRTIs, specifically efavirenz, showed promising results with no difference in low-level viremia or virologic rebound. Several larger studies then demonstrated non-inferiority of 5 days per week and alternate day NNRTI-based regimens. Larger observational studies then showed that 4 days a week of either NNRTIs, boosted protease inhibitors, or second-generation integrase inhibitors, or INSTIs, could also maintain virologic suppression. Then, in 2023, Quatuor, in which more than half of participants took INSTI-based treatment, found non-inferiority of 4 days per week ART. And pilot studies of bictegravir-based regimens have now showed no differences in virologic failure. Duetto and Breather Plus are more recent and important studies of intermittent therapy, which we'll discuss in more detail later on. Duetto considered intermittent 2-drug ART, while Breather Plus considered triple ART. There is another particularly urgent reason to talk about intermittent ART, however. It should go without saying that it is essential that people living with HIV can access uninterrupted person-centered care, including ART. However, in the current global HIV funding crisis, this access is at risk. In January this year, the US President Donald Trump dismantled US aid. Following a stop work order with no warning, clinics closed overnight. The USA had been providing 73% of all donor funding for HIV programs in lower middle-income countries. Much of this was through PEPFAR, the President's emergency plan for AIDS relief. Countries in Europe have also substantially cut international aid. In the UK and France, there are planned aid cuts of more than 40% by 2026, and in the Netherlands, this figure is 70%. By this March, CHI had reported that at least 8 countries were at imminent risk of national-level ART shortages. Critically, though, supply chains have also been disrupted in almost half of countries surveyed by UNAIDS. Clinics have been closed, records destroyed, outreach workers have lost their jobs, and the networks that people relied on to access ART safely and without stigma have been torn apart. This graph shows the predicted increase in HIV-related deaths due to these aid cuts. With the loss of PEPFAR included, an additional 1 to 3 million HIV-related deaths and 4 to 11 million new acquisitions are predicted over the next 5 years, the purple area on this graph. It's recently been announced that PEPFAR will not be cut in its entirety, but it is still expected to be cut by billions of dollars. ART shortages are therefore already a reality. There are widespread reports from UNAIDS, CHI, frontline reporters like MSF, and grassroots agencies like GroundUp that people have been forced to stop ART in Mozambique, South Africa, Zimbabwe, and many other countries. In this context, a team and I conducted a meta-analysis of intermittent ART efficacy as a potential way for people to extend the ART supplies that they have left. In March, we compared triple ART, taken 3 to 6 days per week versus daily ART, in people with HIV-1 of any age. Risk difference for efficacy, assessed through HIV viral load greater than 50 copies per mil at the longest available time point, were meta-analysed in RevMan with a random effects model. And where available, we descriptively analysed intention to treat viral suppression, highly sensitive viral load, treatment emergent drug resistance, adherence, acceptability, and measures of inflammation, which were interleukin-6, D-dimer, and highly sensitive CRP. And we supplemented this with a rapid scoping review of observational studies. We did not include safety data, primarily because the safety benefits previously seen are likely to be related to reduced efavirenz doses, and efavirenz is now less widely used than dolutegravir-based ART in a global context. 8 studies across 4 continents with 24 to 72 weeks of follow-up were included, and these primarily evaluated NNRTI and INSTI-based regimens. In total, 1,346 individuals were included, or 673 per arm, and 22% of whom were female. Quatuor, Breather, and ATAD had the largest sample sizes. Other than in Breather, participants were adults, and prior time on average on ART was 1 to 8 years. In the intermittent treatment arms, ART was taken 4 or 5 times per week consecutively, or 3 times a week on Monday, Wednesday, and Friday. All trials included people who were virologically suppressed for at least 3 months on daily ART, and all trials excluded pregnant people, and almost all excluded people with hepatitis B. 4 trials required high baseline CD4 count. 5 excluded people with HIV with study drug resistance, and 2 excluded people with previous treatment failure. Viral load monitoring was intense, usually at least every 12 weeks, and trials were mainly conducted in high-income countries. And populations may therefore not be representative of settings with less access to these baseline tests, resistance testing, and viral load monitoring. 2 studies had adherence-based criteria, with Sunital requiring 2 weeks of 100% adherence, and the tri-week excluding people with conditions felt to compromise adherence. With this in mind, we found no difference in efficacy between intermittent and continuous therapy. This graph shows the percentage of participants who experienced confirmed virologic failure, defined by most studies as 2 viral loads above 50 copies per mil. Of note, all studies which were powered to detect non-inferiority did so. As shown in this forest plot, the risk difference for efficacy was 0.00, with no difference between intermittent and continuous ART. The p-value was 0.54. This graph shows the percentage of individuals with HIV viral loads less than 50, where missing data was considered treatment failure. Again, results were very similar between intermittent and continuous ART. 4 studies measured highly sensitive viral load, with HIV limits of detection between 2 and 20 copies per mil. The proportion of participants with viral loads below these limits were very similar in both arms of these studies. Because intermittent ART studies intentionally reduce dosing to almost the minimum safe level, suboptimal adherence could confer a high risk of treatment failure. 7 of 8 studies measured adherence, usually through self-reported questionnaires reporting on missed pills. Adherence was typically very high, above 90%. The success of intermittent therapy in these studies might therefore have relied on this excellent adherence. ATAD used SMS reminders to support adherence in both groups and found better adherence with intermittent therapy. Intermittent therapy might promote adherence through improved acceptability. 4 studies reported on quality of life and treatment satisfaction, with participants favouring intermittent therapy in all 4 studies. For example, some young people in Breather felt intermittent ART subjectively reduced side effects and eased the pressure to remember ART, making weekend socialising easier. 4 studies measured genotypic resistance in instances of virologic failure, and this was considered treatment emergent given the lack of resistance or previous treatment failure at baseline. Overall, 69% of successful genotypes showed resistance with intermittent ART versus 67% with continuous ART. And this amounted to 1.9% and 2.1% of participants, respectively. In instances of intermittent ART treatment failure, overall, most resuppressed with a return to continuous ART, or occasionally a regimen switch, and only 1 participant taking intermittent ART did not resuppress despite switching regimen, versus 2 in the continuous ART arm who switched regimen. Chronic immune activation after viral rebound is associated with adverse outcomes, and 3 studies measured inflammation biomarkers, and they found no differences in D-dimers, highly sensitive CRP, or interleukin-6, other than slightly lower D-dimers with intermittent ART in breather, suggesting that intermittent therapy does not result in subclinical inflammation. Finally, we identified 6 observational studies of intermittent ART through our original search criteria, and populations were similar to the included randomized trials. Overall, raised viral load was really rare and occurred in 4.4% of participants at 48 weeks. So what can we take from this? Overall, there was no efficacy difference between intermittent ART taken 4 to 5 days per week versus continuous ART. However, these populations had excellent adherence and were virologically suppressed at baseline without previous treatment failure or baseline genotypic resistance. In settings with less frequent viral load monitoring or resistance testing, switching after treatment failure might be less rapid and could compromise outcomes. Based on these trials, though, and particularly the Quatuor trial, which was large and included people taking instis, the French HIV treatment guidelines now recommend intermittent triple ART taken 4 to 5 days per week as a simplification strategy for people who are virologically suppressed. There are important caveats, though. For instance, ensuring that someone has no history of treatment failure or resistance and no hepatitis B co-infection. Other situations for which this has not been shown to be safe include pregnancy, HIV-2, and with drug interactions such as TB treatment. Studies also excluded people living with TB. Resources like online drug interaction checkers are also set up for daily ART. And for example, fewer doses of dolutegravir each week could exacerbate interactions with drugs like rifampicin, such that the advice and suggested dose adjustments no longer safely apply. But can these results be used to justify intermittent triple therapy in low and middle income countries? There are several issues to consider. There is limited access to resistance testing and viral load monitoring in many low and middle income countries, further exacerbated by the international aid cuts. So the strict baseline criteria could be harder to confirm and virologic failure harder to detect. Importantly, globally, the vast majority of people living with HIV take dolutegravir-based regimens, specifically tenofovir disoproxil, lamivudine, and dolutegravir, or TLD. Fortunately, baseline dolutegravir resistance is currently very low, and resistance was reported by only 1 of 11 reporting countries in WHO's 2024 report, with a prevalence of just 0.2%. However, dolutegravir's half-life is 14 hours, which is much shorter than efavirenz 45-hour half-life, as efavirenz is extensively protein-bound. So far, none of the 8 studies have evaluated intermittent dolutegravir in low and middle-income countries, especially without resistance testing or with more realistic frequency of viral load monitoring. This brings us to Breather Plus. This trial finished this summer and it aimed to address some of these questions. It also looked at adolescents aged 12 to 19, as this is historically a population with particular barriers to adherence and potentially greater long-term toxicity from ART. Breather Plus enrolled 470 virologically suppressed people with no previous treatment failure in Kenya, South Africa, Uganda, and Zimbabwe onto either 5 days per week or continuous ART, specifically TLD. And they received viral load tests every 6 to 12 months, aligning with standard of care in these settings. 23 or 10% of individuals taking intermittent ART versus 11 or 5% of those taking continuous therapy had confirmed virologic rebound. Using the safe or smooth away from expected non-inferiority margin method at 99% confidence intervals, this did not show non-inferiority. And at 95% confidence intervals, intermittent therapy was inferior to continuous therapy. In other words, it was worse. Why were these results so different to previous studies? These results were really unexpected and raise important questions about where to go from here with intermittent therapy. Was it due to low adherence? Is it pharmacokinetics and dolutegravir's shorter half-life? Was it due to dolutegravir resistance or perhaps the way the trial is set up? Adherence seems an unlikely explanation, as at 96% of visits, participants self-reported optimum adherence in the last 7 days, And while diaries are an imperfect way to measure adherence, this is similar to findings in previous studies. The young people were also selected to be very adherent. They had no history of treatment failure and had been virologically suppressed for 12 months. Could it be due to the PK and dolutegravir half-life? Previous studies of intermittent efavirenz that measured drug levels found that efavirenz levels either did not drop substantially or dropped somewhat but remained above established minimum inhibitory concentrations with intermittent use. And similarly, several studies of intermittent bictegravir, which has a slightly longer half-life than dolutegravir but a much longer intracellular half-life, found that levels still remained above the minimum inhibitory concentrations. It's possible that dolutegravir's shorter 14-hour half-life led to reduced efficacy when taken less than every day. So far, we've been focusing on triple ART, but the recent Duetto trial, which also evaluated dolutegravir, but in this case 2 drug regimens, 4 times a week, also showed that intermittent therapy was not non-inferior to continuous therapy. However, in the 8 individuals with virologic failure on intermittent therapy in that trial, only 2 had low drug levels, so dolutegravir's half-life might not be an adequate explanation. Was it due to resistance? In Duetto, there were 2 unexpected cases of baseline ART resistance in people who had treatment failure, and it's possible that underlying INSTI resistance is compromising outcomes in intermittent dolutegravir-based ART. But prevalence of dolutegravir resistance is thought to be really low, and dolutegravir is considered to have a high barrier to developing resistance, so this also seems unlikely. Could it be linked to trial design and how endpoints are selected? When people develop viremia on dolutegravir, in the vast majority of cases, people resuppress with adherence counselling. And this also happened in Breather Plus. There were some viremic episodes where participants and their clinicians remained blinded to the viral load results, and so they continued intermittent therapy. And in the majority of those cases, people resuppressed on intermittent therapy. WHO recommends a viral load cutoff of up to 1,000 copies per ml as representing viral suppression in resource-limited settings. And so if 1,000 copies per ml, rather than a stricter 50 copies per ml, had been used in the outcome in Breather Plus, this might have given people a chance to resuppress without needing to stop intermittent therapy. Might non-inferiority of intermittent therapy then have been shown? It's completely impossible to know, and running a trial using a less strict cutoff could be unethical, especially now that the inferiority margin of Breather Plus with a 50 copies per ml cutoff has been shown. Ultimately, the unexpected Breather Plus results may have been due to a combination of factors, and it's still an open question, and so if you have ideas, I would be really interested to hear them. Perhaps the more pressing question at this moment, though, is what advice, if any, can we give someone who is about to run out of ART in the current funding crisis? These are real questions which the HIV Information Service, HIV iBase, has recently been asked. This diagram shows how ART taken 4 or 5 times per week could help extend what is left, so that if, for example, someone had a 30-pill bottle left and couldn't obtain more for 8 weeks, they could spend only half a week off ART with intermittent therapy versus nearly 4 weeks with continuous therapy. I would like to thank the co-authors of the systematic review, as well as Dr. Nidali Ramesh and Dr. Toby Pepperell for their valuable contributions, and also to Unitaid and the ITPC for supporting the systematic review work. And thank you very much for listening. I'm very sorry to not be with you in person today at what sounds like a really fantastic event, but I'd really welcome any questions, and I've left my email address in case you're happy to send any. And I hope you enjoy the rest of the day. Thank you.